Hi, everybody. I'm Dr. Funke Afolabi-Brown, and I'm so excited today. I'm always excited, actually, on our Candid Conversations, because today we're going to have a very insightful and engaging conversation on the airway in kids. And I love this title, Breathing Red Flags That Every Parent Should Know. So many times in my practice, people say, oh, yeah, it kind of snores a little bit. I think it's cute. And I'm just like horrified. And I met Dr. Marielly a couple of months ago, and we just like hit it off. And I said, you know what? I need you to talk to my people. You need to come on here and just share your wisdom, because we are just so in sync in the way we see the airway and breathing and things like that. And so that's what we're going to be talking about today. So super excited to have you today, Dr. Marielly. Can you just introduce your awesomeness to my people?
You're so sweet. Yeah, I'm so excited to be here today too. And I like to piggyback off our conversation. I was just like, I ended that conversation being like, where have you been this whole time? Like, I've been looking for you. So I'm so excited that we met and that we're, fostering this relationship too, in the sense and being on here. And I think the message that we both share is so important. And so, yeah, but to circle back to your question, my name is Dr. Marielly Mitchell. I have a doctorate in occupational therapy and the founder of Therapy LA. It's a pediatric therapy center here in Los Angeles, where we focus on airway and sleep health in combination with traditional occupational therapy, focus on sensory motor integration, primitive reflex integration, and our speech therapy department does speech therapy with orofacial myofunctional therapy as well, and sleep and airway health and feeding. So we really look as the mouth as like an oral portal into health and wellness, and it is one of the pillars of what we do and the foundation of what we do. I really believe that breathing impacts behavior and through the process of sleep specifically. So, yeah, you're my people.
All of the above, all of the above. I love it. How did you get into this field? Because I think that's just your journey is just really fascinating, honestly. So tell
Yeah.
us a little bit about that.
Yeah, my journey is interesting because there's not a lot of OTs who do what I'm doing. And so the
Mm,
reason why that is because I studied right out of school. Neuro was my first love, sensory processing. I went to USC and Jane Eyre's. That's where the science of that was founded. And so I learned under her prodigies, which was I'm very like a neuro nerd. That's my thing. And I also went into feeding because I found that really fascinating, how that could really change the whole family dynamic when the stress level of would decrease when a child would start to eat. Like I really noticed that. And also when the child would eat, everything got better. Like these biological and physiological needs really spoke to me. And so when I started doing more feeding, I got an SWC, which is it's a post master's type of certification that OTs in certain states can get. And we can do like modified barium swallows. We can do a lot of more like that, more medical based, what like speech and language pathologists can do. We're never them, but we can do a lot of what they do in that regard. And so that kind of led me into the mouth. And when I started going in more deeper into the mouth and seeing how important this was for so many occupations, I was introduced into orofacial myofunctional therapy. And that's where like my life totally changed personally and professionally. And that
mm,
became, I noticed all the things that I had with orofacial myofunctional disorders growing up with ear infections and poor sleep and my nervous system and ear infections into my early 30s, like, and tinnitus, like really severe things that were life altering for me and the quality of my life when they were really exacerbated. And I started to see them everywhere in the kids, right? And it's not because I was just looking at that lens, like that's actually what was happening. You know,
mm.
chronic ear infections, chronic tonsillitis, mouth breathing, sleep issues, etc. Like when you start to ask these questions, these kids actually have these issues going on. And so that's kind of what happened. And that was about like 9 years ago when I got into the airway world. And, I just love learning. And when I start to learn about something, I go really deep, really fast. So I flew all over the country as much as I could to learn as fast as I could about it. And I'm still learning about it. I think we all are as an industry. It's a fascinating subset, I think, of medical, specialties. And with the technology, with what's happening with Aura rings, Whoops, the accessibility of sleep image rings and things like that, I feel like as a society, we're just learning about sleep really to how it impacts us. And so I'm constantly learning about it, and that's kind of how I got into it. So yeah.
I love all of that. So maybe we'll even jumpstart and say, why is it so important? Why is it that the way a child breathes, like you said, it affects the entire lives, right? Why is it that the way a child breathes, why does it affect their sleep?
Yeah, great question. So when a child is the way a child breathes, not and it's not just a child. These are principles of biology, physiology, neurology. I just happen to apply it in the pediatric world. When someone's breathing through their mouth, they immediately go into a state of fight or flight. Your brain perceives that as gasping. I tend to work with a more fragile population with their nervous system that's not integrated. They have sensory processing challenges, learning differences, or ASD, ADHD, etc. And so when you already have a nervous system that's having a harder time, functioning in the world that we live in today, and then you have a biological and physiological factor that's not functioning as it should, it exacerbates your neuro symptoms significantly. And that's really the connection that our clinic makes and what we work on. And it really has been so revolutionary to me as a clinician, of how when I start to work on the mouth, or the airway gets opened with expansion or tonsils or adenoids, or steroids, whatever we need to do medically to help this child breathe better, they start to sleep better. And again, we're just starting to understand sleep and how this really is where our brains and our bodies and our souls recoup, right? And I feel people don't understand that yet. And I think because a lot of people also don't sleep well themselves. And so they think if someone's just not making noise and they're sleeping great, but that's really not true. Or if they're sleeping, enough hours, and it's fine, but it's about quality, not quantity. You want good quantity too, but it really can influence so many parts of the brain. And people, I think, also forget that these little babies, whether they're 7 months or 17 or 7 months, like their brains, or 7 years, their brains are still developing. They can't take on these insults constantly every day. And it's a compounding, silent thing that's happening that people don't really understand, because they're also sleeping too. So it's hard to find clinicians who are also going to find and ask the right questions to get to that level of depth to see, is this a barrier of entry for you, for your child to make progress? And that's kind of what we see a lot here, unfortunately, which is just the truth of it's a silent epidemic is what it is.
It is. And you're so right. I think we've almost been cultured as a society to think, oh, maybe the fact that I hear them breathing means they're really sleeping, right? Oh, wow, deep sleep is snoring. They must really be sleeping. And it's just so scary. So maybe walk us through, before we even talk about, maybe, yeah, tell us first, what are the signs that a parent should be concerned about when they say, my child is snoring? Like, what are some of the signs for you in your role and with your practice and the work you've done? What are things that red flags where you're like, oops, okay, nope, okay, nope, okay? Because most people just think, oh, snoring. But beyond snoring, there are other signs, there are other symptoms. So maybe walk us through some of those kind of
Yeah.
red flags when it comes to breathing.
Yeah, absolutely. So we have like a sleep screener too, if people want to find that through like our social media or anything like that, with a lot of the questions that we ask on our intake. But we always ask about snoring. We ask, can you hear your child breathing? Is your child tossing and turning? Are they walking or talking in their sleep? Teeth grinding is another one that people think is very normal or common, but it's not. I essentially describe it as that's like self CPR from the brainstem, trying to get the airway to open from a more to get more diameter. Like it's opening. People really don't understand that. Tossing and turning is also the brain trying to get the tongue usually out of the airway because it's blocking it. When they also wake up, are they waking up really upset, like grumpy, groggy? Or maybe they have a really big cortisol spike and they're really hyper. There's really there's a Goldilocks zone where people should feel refreshed and calm when they wake up, and that's really not the case. Bedwetting is another red flag that people tend to not really understand is something like that, or they think it's behavioral. Bedwetting is a big one, especially if a child was potty trained previously and then has a regression. That's something that really needs to be investigated, because that's definitely a connection between the heart and the stress response with the brain, and not enough oxygen going around. Those are some of the main ones that we ask for. Open mouth posture when they're sleeping. And one that people don't really think about a lot is tripod sleeping, when a child is sleeping on their stomach with a lot of neck extension and their tush in the air. That's that child trying to open their airway. It's kind of like, it's not that I don't like this example the most, but I can't think of a better one. But when someone's, trying to get air when they're swimming and they're drowning, what do? They extend their neck, right? So if you've got children who sleep with full, like a ton of neck extension, that's a person who's really trying to open up their airway as much as they can. And that's something that I think gets overlooked a lot. The positioning of sleep is really important to note, and the peacefulness of it. If it's not peaceful, then that's an issue. Like I always tell parents, like, you actually kind of almost want to think that you need to check on them because they're so quiet. That's good sleeping. Where you're like, are they good? Or because it's so quiet and peaceful. that is good sleep, right? Tossing and turning, waking up screaming, having nightmares, night terrors, that's the nervous system telling you I'm in fight or flight, even when I'm asleep. And that's or moving around a lot, your motor cortex is firing. Like that's not restful. And a lot of parents just think that's really normal. Waking up to go into the parent's bed multiple times a night, that's another one that people think is really normal because it's common. But I think if one of the one things I always mention is just because it's common doesn't mean it's normal, like snoring, right? And that's something that we've normalized as a society, and we've also kind of culturally made things it's cute, and there's just snoring a little bit, and it's like it's never a good sign. The more someone snores, the less oxygen they're getting, and that's an issue. So there's a lot of like signs for sleep disordered breathing, which I call like the stepsister of obstructive sleep apnea, and that's you're getting there. You're on your way to obstructive sleep apnea if that's the case.
Very helpful. I love that rundown. So, why is this happening? Right? We've said it's abnormal. Why on earth is my child, mouth breathing? Like, what are the things that you find are causative, that makes a child suddenly have this open mouth posture and all of that? And I think this is helpful, which is what I really liked about how comprehensive your program is, because sometimes, depending on what the cause is, we can then sort of create a plan of action.
Yeah, absolutely. And I think, I think it's a combination of things. I think it's epigenetics. I think there's genetic predispositions with craniofacial structures. And what I mean by that is how the bones and the facial features are formed due to genetic influences. And then the environmental factors of, how long were they using it? In America, especially, we see a lot of this because there's not enough maternity leave. This is a systemic issue as well. This isn't like a one-on-one personal family issue, and that we're at the mercy of there's not enough maternity leave and support for women to breastfeed. Breastfeed is children who are breastfed have a better chance of jaw development because the breast tissue squishes up against the palate and the tongue has full range to widen the palate, right? Bottles and pacifiers do the opposite. They separate the tongue away from the palate and they make the palate more vaulted and more narrow, which the roof of the mouth is the floor of the nose. And that's where this section starts to get a little bit hairy when things can't form as they should. And so if your palate is too, I have a puppy usually, when your palate is too vaulted, then you don't have anywhere for your tongue to go. And so your tongue then drops down and your mouth is open and your tongue will usually go forward, right? And the mouth stays open. Even a lot of people will say, oh, but his mouth isn't wide open, but it's still like this, right? That's still an open mouth posture, and people kind of need to know that. So the physics of it is really related to what was that child exposed to in their mouth during those formative years. And those formative years are a while, right? And so it's all about pressure and what pressure was put in the mouth. Just like if a child's left on their back for too long and their head gets flat, the same physics, but in the mouth. The issue is that the airway is there. That's the crux of everything that makes this more complicated. And so extended pacifier or bottle use or digit sucking or things like that can really narrow the roof of the mouth, and then therefore the lower jaw, the mandible, will follow suit and usually goes backwards like a retrognathic jaw, and it'll make the airway diameter a lot smaller. Or you get an underbite too if the tongue's resting forward and the jaw comes forward. So it can really mess with jaw harmony, which is then therefore the airway of the architecture of the airway is compromised. So
I think that's a beautiful explanation. Are there any other? I mean, I think that's absolutely right.
That's like the first step that kind of happens. And then when children are kind of on packets and sucking on those packets for a long time, or they're on a puree diet for too long and they're not, people need to also remember these are muscles, right? And these are muscles that support your airway in one of the most fragile areas of the body with the most funky little cervical spine that has all these rotations. You're at the mercy of muscle and soft tissue here. And so you have to work them out. And if you are sucking for too long, or you're just slurping, or you're on purees, everything is just going to go. It's not taut and toned, right? And that's what you want. I tend to call for analogies because I like to explain things as best as I can. The tongue, the core of the face, and the jaw is the hips. And if your core is deactivated, everything else kind of follows. And then your face has poor posture, right? Then how can you do jumping jacks and somersaults, which is like eating or talking, right? You use the same muscles for talking that you do for eating. And so much of that is based on how the anatomy is really the baseline of that anatomy's quality. Is it where it should be? Do the teeth align? Can the tongue have a place to rest? Can it touch the palate at the right spot to make the right sound? It all really goes back to the anatomy, and the anatomy can really get compromised with what's the first impressions that the mouth gets, right? And some people, preemie babies, like there's no choice, they have to be bottle fed, and that's totally fine, and I'm hyper aware of those things, and not everyone can breastfeed. I'm hyper aware of that, and I'm not saying that has to happen, but there are now earlier things that you can do, like working with the myofunctional therapist, working with like a myo munchie, which is a little device that we use here in early toddlerhood or even as early as 6 months, and they can chew on things like this, and you can wean them off the pacifier, and it's like doing squats for your face, So it's a combination of why this happens is genetics, but also environmental factors is a big part of what we do with here. And we're not eating like we used to. We're not eating raw foods, and we did a lot of purees for a very long time. Baby-led weaning is now a more well-known approach that really focuses on chewing and jaw development, which is fantastic. So we usually do that or a hybrid here for families.
Okay. I love that. So we've kind of talked through what are things that make you say, okay, there's something abnormal here. Then we went on to talk through why in the world is it happening. Mm-hmm. So I think where I want us to sort of wrap up now is that what now? What should you do? Now you're a parent, you're like, oh my gosh, yes, this child is doing all this stuff. This is super bizarre. These are the reasons, and I'm sure many parents, this is just really to create awareness. So if you're like Dr. Marielly said, if you've been, you had your baby on packets and on a pacifier and thumb socket, there's no judgment. This is really to provide you with information, right? Like, what are the next steps? What should I do, right? So maybe talk us through just maybe generally your approach in your practice, because I think what you do is very unique, so people can know what options are even available.
Yeah, absolutely. So typically when a child comes here, every child, whether they're doing OT or speech, we look at the anatomy of their mouth. And so you, as a parent, what you want to look for in a clinician to address this is that they have a background in orofacial myofunctional therapy and that they're used to working with children your age. The younger they are, most people will do it 4 and over. Not that many places do it 4 and under. We tend to really specialize in that. There's some people who still will do that. And then what you want is a clinician who's also going to collaborate with an airway-centric dentist. That's very key. So you want a dentist who has the lens, who is looking beyond teeth and is looking at the jaw and the airway. They're not just looking at teeth. It's really important that that's the type of dentist. If you're noticing structural changes in your child's mouth already, you can do an intervention quite early for expansion, as like expansion quite early now, and you can really make a difference because the Pediatric Dental Association they just finally kind of got on board with everything we've been screaming at the top of our lungs for like a decade about they're saying 6 by 6. They're like, oh yeah, the earlier we do this, the better. And we're like, yep, we've been saying this for a while. I'm glad we're all here on the same party now. This is great, but it's really big news because now people feel better about it because now everyone's kind of on board in that sense. But the earlier you can intervene with remodeling things, the better it is long-term for everybody. And think about it, now you're going to recoup so much improved sleep for years had you waited till they're 13 or 12 to get intervention from an orthodontic or dental perspective, right? Because if your airway's fine, your jaw's fine, and guess what? Your teeth are fine. That's the thing. You don't have to worry about the teeth. It's the beautiful part of everything. You got to go proximal to distal, not the other way around. That's the thing. Yeah. And so you always want to work with clinicians who work with airway-centric dentists. And if you suspect any sleeping issues or behavioral challenges or sensory challenges or regulation issues or things like that, you want to make sure that clinician you're working with, who's like either a speech therapist or an OT or an orofacial myofunctional like therapist, that they also work with an ENT, someone who will look at, does this child have a hard time breathing? Do they have enlarged tonsils? Do they have enlarged adenoids? Do they have enlarged turbinates? What's going on back there? How can the anatomy back here, more posterior, more proximally, be impacting things? Because the last thing you want to be doing is spending 6 months in therapy trying to make progress when you've actually got a breathing issue and it's not a behavioral issue, right? And that's where I tell my families, I'm like, It doesn't matter what swing I use, it doesn't matter what trampoline I use, what vibration plate I use, like your child likely will not regulate with what's going on with that airway. I can't get them out of fight or flight. I wish I could. I'm just honest. Like my toolbox does not cover that. And you know, when you work in that way, that's how we work a lot with, we collaborate a lot, have a lot of interdisciplinary care. These children leave the clinic. They're not in OT for 7 years. And like, trust me, there's kids who will be with me for a while. Like I'm aware of that. But the kids who like typically might have been at clinics for a long time, or they've already been in clinics for a long time, they graduate in a year, they graduate in 18 months. And it's because we get to the root of what's going on. And then the best part is that therapy can penetrate, activate, and then they can integrate and regulate. That's the thing. And when you open up the airway, you open up the mind for so it can be stimulated. That's the main thing. So you want to work with people who know orofacial myofunctional therapy and also have a team of people that they can refer to if your child needs more investigating, really. And I also want to emphasize, I think talking to your pediatrician is always really important, but you also have to remember that generalists are not specialists and they can't answer specialist questions. And so please don't, you can take that with like, I love pediatricians, I refer to them and vice versa, but we all have our place. And it's really hard for parents, I think, to understand when a generalist says or dismisses their concerns, that you have to find the people who validate your gut instinct. Like you are neurologically connected to your child, like no one knows them better than you do. And finding the people who are going to listen to you and do run the tests to kind of see what's going on is really important. And that's something where specialists who actually really know this area of medicine are the ones who can answer those really like deep questions, like what's going on with they're grinding their teeth, or what's going on with this, or why do they have all this like reflux, or what, all those kind of questions. Ask specialists. That's why we exist, you know. So yeah.
I love that. I love all of that. I think I just like how you've, sort of, it's almost like full circle. We started off talking about this experience where you now understand, like, breathing is meant to be quiet. There's nowhere that noisy breathing means air is struggling to get in because of one reason or the other, right? And we've talked through a number of reasons. Sometimes you might have, even in addition to this, you might have a child who has just overall low tone due to a genetic syndrome. And I think in those situations, you want to even be more aware. And it's so important. Sometimes you might have a child who has structural issues, like we talked about, craniofacial problems, all of those things. Getting to the root cause is so important. And then from there, advocating. You have to advocate, because I can't tell you how many folks, and again, I work very, very closely with pediatricians. I mean, they do an amazing job, right? They are incredible, right? They're the first line. But in some situations, if you feel like you're not being heard, then just keep asking those questions and find the help you need. This is so, so good. And it might end up being, it actually has to end up being a collaborative approach, right? There's no, I know my zone of genius, right? The ENT doctor does things that I do not do. I do things the ENT doctor doesn't do. An expert in myofunctional therapy is doing things that I do not do, right? A dentist, an orthodontist, an airway-informed orthodontist. It's so important to have them on your team. And what you said really is just makes me light up with so much joy, because now there are moves towards repairing early. Yeah. Getting to the root cause early and addressing it. I'm not saying we're going to wait, it's too young. And I still saw someone earlier this week, 5-year-old, who's like, well, I'm thinking it's a bit early. And I said, no, absolutely not. We're doing this, we're getting this done quicker. And think about how much good oxygen they're going to get for much longer versus waiting.
Yeah, absolutely. Yeah. And, I do want to also say, like, that interdisciplinary approach, like, trust me, it's a lot for people. I want to also acknowledge that, like, I'm also like a person and a patient on many levels, and I've been my own journey with myofunctional therapy. There's a lot of cooks in the kitchen, because I can't think of another body part that has more functions, right? Chewing, talking, swallowing, breathing, all the things other than like a woman's reproductive system. So much happens in this area. I call it the Bermuda Triangle. That's like my thing, because I'm like, there's so much that goes on that like behind the scenes that you don't even really think about. And until something's wrong, do people really like almost like respect this area of all the things it does? And that's why there has to be so many people. Like you said, I don't do what an ENT does. Like I definitely don't do what you do. Do you know what I mean? And that's where I know it's really frustrating on the parent and on the patient and all the appointments, but I promise it's worth it when you really get to the bottom of it, because giving your child the ability to get all the oxygen that their developing brain needs will give them the breath that they need for their nervous system to function and for them to sleep. And that is when their brain processes so much information. Like I think like everyone goes is like, you know, the new thing right now is like gluten-free, right? I think like in 10 years, everyone's gonna be like, sleep is the most important thing on the planet. I really do. Maybe 5-7 with AI, and people are gonna understand information will be, you know, given to them in a much more accessible way. But I think really sleep is where your brain recovers and does so many things that we don't even understand. I definitely don't. But I see the difference here clinically and anecdotally all day long when kids start to sleep better. And it is like, they just like, what? Like turn on and start asking these like existential questions like, hey, like what happened to my grandma when she died? And I'm like, you don't even know like what color red was 3 weeks ago. Like what?
Oh my gosh.
My mind.
That's amazing.
And that's where I just want parents to know, like, we're with you along that. Like we understand. And I wish it was easier, not so many people, but it's definitely worth investigating if you think your child has these type of challenges. And especially if you're spending time, energy, resources on therapy, because you want that therapy to work. You definitely do.
Yeah. You want that therapy to work. This is beautiful. So thank you. Thank you for doing this. I mean, your passion is what got me the first time. I'm like, oh my God, this is it. This is it, right? So how do people work with you? Where can people find you?
Yeah. So we have our website is theraplayla.com. We have like a mothership clinic here. We have a great sensory gym, and we also offer parent coaching. And so families can go to our website. And then I also have an Instagram. It's Dr. Marielly, the word doctor spelled out. And I go on there and I post things, and they can find also free resources about primitive reflex integration, or they can also find our sleep screener to see if their child has any challenges with sleep. And if so, then I would definitely recommend scheduling discovery calls. So yeah, so they can do OT or speech with us, and both disciplines cover myofunctional therapy and airway health.
Love all of it. So we put it here. We'll put it in the comments as well. Do you have any final words? I mean, you've said so much and you've shared so much of your wisdom.
Well, that's sweet. You know, I encourage parents to trust their gut and to know that if you're suspecting anything and if you're listening to this, that you're an amazing parent who's already digging so deep, and that your child's so lucky to have you, and to keep following that, and to really, and also I want them to know that if your kid's not sleeping, I know you're not sleeping, and that's really hard, and that you're doing so well just even listening to these types of conversations and getting deeper to the root of issues, and to keep following that and find your people, find your tribe, until you can really get to the bottom of what's going on. And I know we talked a lot about airway, and I don't want to be narrow-minded with that, but this also is in relation to like elimination is important. Kids who are constipated, they should be eating well, etc. Biology really impacts neurology and psychology, and you want to cover those bases and those foundations, and as best as you can, right? And optimize what you can. But this is, I think, something that parents can really look for. And there's a lot of people getting into this because we're realizing how much it impacts, you know, behavior. Truly, it impacts everything.
Yeah. What a powerful way to end. And I would encourage everyone, if whether you're watching this now, whether you watch it on replay, you need to follow Dr. Marielly. I mean, incredible content. Website is just loaded with so much information. So definitely check her out. I just think the work you do is so much needed. And so thank you so much for doing this work. And if you're out there and you're like, where do I start? How do I start? You know, we've shared so much information with you. I mean, at the Restful Sleep Place, we'll be more than happy to help you on that journey. If you have, you know, medical sleep issues, you know, behavioral sleep issues, we kind of help provide kind of a blueprint to what does good sleep look like. And then these are the kind of doctors and clinicians that we're really collaborating with that get it, right? Like I said, I'm not a one-stop shop. I do not do all things. At the end of the day, the goal is good sleep, and there are different pathways to get you there. And we build that for you, and we'll be more than happy to join you on that journey. So you can check us out at therestfulsleepplace.com. My goodness. This was good. So if you're out there, this is one you want to share, you want to keep and just watch again and again. If
You're
you
so
have a
sweet.
noisy breather in your world, you do want to send this to them.
Yeah, absolutely. Absolutely. Oh, I had so much fun today. Thank you for having me. Oh, I could
You're
talk to you
so
forever.
welcome. You're so welcome. I know, same here. All right, everyone. Until next time, I hope you rest well.